Okay, good morning, everyone. My name is Abhishek Kumar, and I welcome you all in this very morning session. In this session, we have four fantastic presentations, and this session is about how we can improve the knowledge and capacity of facility and community-based FP service providers to counsel the women in the community. And in this session, evidence from countries across the world will be shared. Like there will be evidence from India, from Afghanistan, and and discussion session. So my request to the presenters is be on the time. Try to finish your presentation in 15 minutes so then we will have more time for the discussion and the question answer. And my request to the audience is please keep noting down the questions or query so that after the presentation is over, there will be engaging session. So with this, I would like to invite our first presenter, Dr. Padma Bugineni, who is associated with Care India. So Dr. Padma, please.
Yeah. Good morning. Thank you for coming and attending our session. And it's an honor for us to present our work in Bihar. I'm Padma Bugineni. I work as team lead in family planning in Care India and very specifically in Bihar. Today, I'm going to share stories of change with you. Right? These stories are so empowering and very stimulating for everyone to know and understand the process that we adopted in order to bring the change. Right? And the stories of why our stories matter, because our stories are about our people, the challenges they face, and their passions, right? And this is the session, but we are going to narrate our experience in the form of small stories, right? And where did the change happen? So the change, yeah. So the change happened in India and in a state called Bihar, especially in two districts of Bihar, which are called East Champaran and Gaya, right? So why there is a need for us to think of change? What happened? What actually driven us in order to focus on bringing change? So those specifics will be narrated by my colleague Komal, but I want to provide a broad overview what actually helped us to bring that change and who we worked with. So in this particular context, we have worked with the frontline workers who are called ASHAs. So, and then why did we focus on ASHAs? Because as you all know, women and girls are at the center of care programs across the globe, right? And then these participants are also women, and care works with government of Bihar. It's not a unidirectional support to the government of Bihar, but we collaborate with the government of Bihar and then co-design programs. So when we work together, we realize that in this particular program, it is important to build the capacities of frontline workers so that they can reach out to the communities with accurate information and also provide services. And in the process, we have deliberated so much on what kind of tools we adapt. We know we are going to adapt participatory tools, but we also deliberated so much that what tools would help us to enable these frontline workers to engage in the program. Right? So then we came across about this particular approach called social analysis and action. So what is this social analysis and action? This is an approach and model developed by CARE USA, which actually helps in developing gender transformation programs and also helps you to reflect with the community. That's what mattered to us, right? And then there are several steps also in this approach. It also helps in transforming the staff capacity who engage in the program and also support the frontline workers to help the communities. So the first step is to transform our own capacities as staff. And then once we transform, and it's about reflecting with the community and then plan our work and execute the work and in the end evaluate the work. So it's a systematic process that has led to the change in our program, and that those are the stories that we want to share with you. And taking one step backwards, before actually finalizing this SAA approach, we also had a field level interaction with the community and also understood the relationship between the poverty and poor health and also power, and how these combined together influence the decision making at the community level and also with the women. So, and then we also looked into Professor Sen's capabilities approach to a beta, because we wanted to understand what capabilities we want to build, for whom, why we want to build the capabilities. Because we know that there are variations in the interpersonal variations in the capabilities of humans. We all have different capabilities. And also based on our capabilities, we will be able to perform or we will be able to access resources. How much we will be able to do actually matter to us. And this approach was adopted to the FLWs because there are several variations in these FLWs. Some are young and have no exposure to training, illiterates. Some are had primary education, some have completed secondary education. So with these kind of participants attending the training, we thought SAA would fit better. And then we have developed the tools and contextualized to the Bihar context. And then it actually brought transformational change within. So that's what we expected. Change within was most important for us when we wanted to build the capacities of FLWs. So without taking much time, I'll request my colleague Komal to take you through the journey of change that happened specifically in the program. Thank you.
Thank you, Padma, for setting the context. Good morning, all, and I'm Komal Kumari, working with Care India in Bihar. It's a pleasure to have you all here. Today, I will take you through the journey of change within. It's really exciting and enriching experience which we have learned in our project in Bihar. Bihar has a complex social structure and value system. Patriarchy and gender is deeply ingrained. It acts as a barrier for family planning services, especially for the young couple. Imagine a girl married before the age of 18, going in a new family where family and society has lots of expectation from her to become a good mother, to become a good wife, a good daughter-in-law, have a child within a year of marriage. So with all these expectation and the responsibility to fulfill these expectation, she don't have any space to think about family planning. So how we are going to build the project for, why we need to build the project for that, to address this issue. CARE did a survey of currently married women of reproductive age group in 2016. And it shows that 61% of women married before the age of 18. She has, by the age of 25, she has 3 children. And at the age of 25, she started using contraception, that is permanent method female sterilization. In these 9 years of gap, there is no use of modern contraception. So clearly this survey threw light on two critical issues that are there is no practice of delaying or spacing among the pregnancy, and the other is there is no mechanism to reach out to these young couple with the information on family planning. So how we are going to, in order to reach out to this young couple, State Health Society Bihar and CARE has co-designed a pilot, which is called Zero and Low Parity Pilot, and implemented in two districts of Bihar, which was mentioned earlier, is Champaran and Gaya. The objective of this pilot was to share the information and benefits of delaying and spacing in the pregnancy to these young couples. So who could be the best person to do it? We thought of deliberate discussions happened, and we thought of the field learnings. So frontline workers are the best person who are there as a linkages between the community and the health system, and they are best suited to our context. So we thought of building their capacities. As Padma shared earlier, that we adapted social analysis and action approach and modified as per our need and it suits to our context. These the modules were designed in such a way that it gives an opportunity to the participant to have interaction with each other, experience sharing with each other, and these interactions help them to have a trigger to think of the situation of a woman in the community because they have been to this similar situation in their life. They have been gone through early marriage, early pregnancy, having tubalization at the early age in her life. So it was a trigger for them to think of how they can change the situation now as a catalyst for the other women in this community. So along with social analysis and action, we also build their capacity on fertility cycle, healthy timing and spacing of pregnancy, benefits of family planning, and the service delivery of family planning. All these things help the frontline worker to become more confident, and they can interact with the community more confidently, clearly, and it has also impact on their working style. They work more systematically, and the inhibitions regarding discussion around family planning with young couple has gone. Now they can, it helped also the beneficiary, the couples to have open discussion with the ashas and then have to decide on their family planning needs. So we talk about changes, and so here we can hear from the field, the ashas.
काम करते हैं आशा का और परिवार नियोजन के बारे में ऐसे हमको जानकारी नहीं था। मैडम हमको बताने आती थी लेकिन हम नहीं समझते थे। वो हमसे बात करना भी चाहते थे लेकिन हम बात नहीं करते थे उनसे। हमको समझ ही नहीं आ रहा था कि हम क्या समझे। वो बता रही है फिर भी हमको समझ नहीं आ रहा था। लेकिन अब मैडम मीटिंग कराती है, बात करती है तो हमको समझ में आ रहा है। तो पहले घर से भी बाहर नहीं जाते थे, हमको बहुत शर्म लगता था, डर भी लगता था, डर जाते थे उनको देखकर कि वो आ रही है हमसे क्या पूछेंगी, हम क्या बताएंगे उनको, हमको शर्म भी लगता था। लेकिन अब शर्म नहीं करते हैं, घर से बाहर जाते हैं, सबसे बात करते हैं और मीटिंग में भी नहीं जाते थे लेकिन अब मीटिंग में भी जाते हैं, सबसे बात करते हैं परिवार नियोजन के बारे में। ऐसे लेडीज से भी बात नहीं करते थे लेकिन अब पति लोग से भी बात करते हैं, सबको समझाते हैं। जैसे आरआई के दिन भी सबसे बात करते हैं। अब डर नहीं लगता है किसी से बात करने में। सास आज भी कहती है कि तुम काय काम करने जाती हो, घर में रहो, मेरा इज्जत चले जाएगा। लेकिन हम कहते हैं कि नहीं, हम काम करेंगे। तो हमें पति भी पहले नहीं देख चाहते थे कि 12 मत निकलो तुम, हमारे माँ बाप की इज्जत चला जाएगा। लेकिन आज हम जाते हैं तो मेरे पति भी सपोर्ट करते हैं। तो हमारी सास बोलती है कि उसी के बनी तुम कहते हो, जो कहती है सही तुम करते हो।
So this was Asha. Asha has also been supervised and reviewed. Their works are reviewed by the supervisors. So here are some of the outcomes that has changed significantly in our learning that the HSE platform utilization has improved. FLW interaction has with their supervisor has significantly improved. So let's see what the supervisor perceptions towards their this change. Let's hear it from the supervisor itself.
मैं रंजन कुमार लाल बीसीएम डोगी मैं पिछले 4 महीनों से पीएससी डोगी में कार्य कर रहा हूँ। इससे पूर्व में फतेहपुर पीएससी में था। डोगी पीएससी में जेडल पीपीएल प्रोग्राम एक चल रहा था। मेरे आने के बाद मैंने इसे देखा। इसमें आपका कम्युनिकेशन स्किल काफी डेवलप हुआ है कि जब मैं रिव्यू करता हूँ तो मुझे लगता है कि कहता है इसमें आपका कम्युनिकेशन स्किल डेवलप हुआ है। अभी हाल में ही पीएससी ट्रेनिंग था आशा का ब्लॉक में, उसमें जब मुझे जाने का मौका मिला, एक आशा बार बार क्या कहता है एजुकेशन के कारण बोल नहीं पा रही थी। इनके द्वारा बार बार उसको मंच पे लाके एक नाटक में उसको पार्टिसिपेट कराया जा रहा था और उसके बाद हम देखते कि 2-3 घंटे के बाद वो क्या कहता है अच्छा बोलने लगी। अभी हाल ही में जब हम क्या कहता है फील्ड विजिट करने गए तो उसको एचबीएनसी के तहत विजिट करते हुए हम देखे। उसमें एक नवविवाहित महिला को काफी अच्छे से समझा रहे थे कि कम उम्र में बच्चे होने से क्या क्या कहता है उसका दुष्परिणाम है। और उसके द्वारा यह बताया जा रहा था कि फैमिली प्लानिंग के साधन के बारे में नहीं बताया जा रहा था। फैमिली प्लानिंग करवाने से क्या क्या फायदे हैं उसके बारे में वो बताया जा रहा था। उसके बाद हम उसको देखे कि फिर वो उसके साधन के बारे में बताए। मुझे लगता है कि जिस तरह से इस प्रोग्राम में क्या कहता है कि आने से आपका कम्युनिकेशन स्किल अच्छा हुआ है और फील्ड में भ्रांतियां भी दूर हुई है। ये 2 ब्लॉक में नहीं, 2 डिस्ट्रिक्ट में नहीं, पूरे बिहार में होनी चाहिए।
So this change within has also reflection not only within the ASHA, it also reflected her work in the community and at the health system level. Ultimately, what is the aim to reach out to the beneficiary? So let's hear it from the beneficiary itself.
मेरा नाम मौसम कुमार है। मेरी उम्र 23 साल है। मेरी शादी का 6 महीना हुआ है। मैं अभी स्टडी कर रहा हूँ। जब मेरी शादी हुई थी तो गांव की आशा दीदी है जो हमसे और मेरी वाइफ से मतलब घर पे मिलने आई तो वो परिवार नियोजन के बारे में बताने लगी आशा दीदी। तो हम दोनों मतलब सोचे समझे 1 दिन 2 दिन 3 दिन, उसके बाद फिर आई आशा दीदी तो फिर हम लोग बोले कि ठीक है। तो बहुत सारी बातें मतलब बताई परिवार नियोजन के बारे में। इसके बाद हम दोनों ने कंडोम इस्तेमाल कर रहे हैं और मैं यही चाहता हूँ कि जब तक पढ़ाई पूरी नहीं हो जाए, जब तक 1 साल 2 साल जो भी हो, इसके बाद ही मतलब परिवार के बारे में मतलब सोचेंगे। हम दोनों पति पत्नी इस संसाधन को पाकर खुश हैं। अभी हम आगे पढ़ाई करना चाहते हैं, इसलिए हम अभी बच्चा नहीं चाहते हैं।
So overall, what essay approach helped us to transform the capacity of frontline worker and help us in reaching out to these young couple at the right time with right information, with right approach. Government of Bihar is also keen to see these positive changes and try to adapt this method in the regular training of ASHAs. So thank you all. I'll end my presentation with a quote that life is always about change. Sometimes it's painful, sometimes it's beautiful, but it is most of the time it is both. So these are the link of the resources we have. We have a small uh, survey for you, just for a feedback for us for the presentation. Just few seconds. So you can scan this barcode, okay? Duplicate. Scan this barcode and then the question will come to you, please. We move to the next question. Next question. This is the next question. The first one. First one, innovation. Shall we move to the next question? Thank you. Thank you all.
Thank you so much, Dr. Padma and Komal. It's really very interesting presentation. So in this series, the next presenter is Falak Raja, who is from India, and she is working with International Center for Research on Women. So Falak, the floor is yours.
All right. Thank you, Abhishek, and thank you, everyone. Good morning. My presentation is on Asha's knowledge and perception on injectable contraceptives and service delivery. And I'll be talking about learnings from a quantitative study and a qualitative deep dive with Asha's that we conducted in the state of Bihar. Just to give you a background, so injectable contraceptive was approved for use in India as a family planning method in the mid-1990s. It was first introduced only in the private sector where it had a cost associated with it. Only in 2016 it came to be included in India's national family planning program within the larger basket of choice, so as to make it available to a larger section of the society who depend on public health services for their general health needs at a subsidized cost. In the following year, in 2017, the government launched the Mission Parivar Vikas, which was basically aimed at increasing the uptake of contraceptives. This scheme was launched in about 145 high fertility districts across 7 Indian states. The state of Bihar is one of the focus states. Out of the total 38 districts, about 37 were identified as Mission Parivar Vikas districts. In this context, where we see that there is an increasing interest from the government to push contraceptive use, the time was right to focus on injectables. Now, to do so, frontline health workers, especially ASHAs, who are the key village functionaries responsible for providing family planning services at the community level, are entrusted with enhancing uptake of injectables, which are commonly known as Antara, by mobilizing women and families. In this role, they are mandated to maintain a list of all Antara users, counsel them on the importance of follow-up care, including side effects, how to manage them, and they also they also ease the access of contraceptives by easing the process at the facility level. With this, the objective of the study is to explore ASHA's role in promoting and facilitating uptake of injectable contraceptives, as well as their own experiences and challenges in service delivery. The specific areas of inquiry that we wish to inquire are around ASHA's own knowledge on injectable contraceptives, the role that they play in shaping perception towards injectables and influence the decision-making process. How do women view ASHA's role in the delivery of injectable contraceptives? And lastly, ASHA's own motivations, barriers, and challenges in service delivery. The study employed a mixed methods design. We conducted qualitative in-depth interviews with current Antara users in the age group 19 to 30 years, as well as those who discontinued Antara use. We conducted key informant interviews with several ASHAs. Further, CARE India also conducted a cross-sectional quantitative survey with frontline workers and a cohort study with Antra users who were then followed up for 2 years. And some of our data points also come from CARE studies. The study site was the state of Bihar, India. The quantitative survey was conducted in all the 38 districts of Bihar, whereas for the in-depth interviews and the key informant interviews, the district selection was based on 3 main criteria, which was uptake of injectables, variation in the modern contraceptive prevalence rate, and geographical representation. Now, coming to the key insights, we know that ASHAs are aware about most spacing as well as limiting methods. Among them, the methods that they recommend the most are condoms, followed by daily pills, weekly pills, injectable contraceptives, and lastly, IUCD. Their knowledge on injectables is fairly standard. They use common descriptions like it's a 3-monthly injection, stop when you want to have another child, it's easily available, you can access it at a government facility, and it causes no harm. ASHAs also possess knowledge about side effects of Antra, but it is not comprehensive. So the most common information that they do possess on side effects is that it causes menstrual irregularity or amenorrhea, followed by dizziness or swelling in the arm. However, most of them are not aware of why these menstrual irregularities occur or how to manage them in case they do. Some ASHAs also reported not being informed about the side effects of Antra at the time of training. Coming to ASHA's perception and their role in shaping demand, we saw that counseling is based on ASHA's own perceptions about method appropriateness. For example, prevailing social norms like the pressure to prove fertility early and son preference meant that zero parity women either did not get targeted by ASHAs or were not recommended hormonal methods such as Antra due to a fear of loss of fertility. Thus, Antra is suggested only to 1 parity women as a method to space till the next pregnancy, whereas higher parity women are recommended only limiting methods and not offered the basket of choice. So ASHAs also build on women's experience and perception around different methods. For example, the use of COPD is often associated with health problems such as cancer, abdominal pain, difficulty in urination. Similarly, with daily pills, women reported missing or forgetting to take the pills every day, which led to method ineffectiveness. ASHAs build on this knowledge and position injectables as a more convenient and an effective method with either least or no side effects. This, of course, goes against the idea of basket of choice and informed decision making. From the quantitative survey also, it was revealed that about only 15% of women received information on all methods during counseling. There is also an incentive which is linked to Antra, a small amount that is provided to both the beneficiary as well as the ASHA on each dose. Now, while that incentive is actually meant as a means to compensate ASHAs for their time and efforts, but it also plays a key role in how ASHAs shape demand for injectable contraceptives when they counsel women for Antra. Coming to ASHA's role as a facilitator, most women reported that they proactively seek information and advice on Antra from ASHAs after hearing about it from other women in the community, which is indicative of the recognition of the role that ASHAs play in the context of family planning. ASHAs also facilitate women's access to injectable as well as its continued use. Most ASHAs accompany women to the facility, and they also help them in reminding about the due date of their next dose. However, the dependence on ASHA in this case is so high that some women even reported missing their dose when the ASHA did not remind them. ASHAs are also entrusted to play a key role in follow-up care. However, as we just discussed, given their limited knowledge on side effects and an eagerness to promote Antra as a relatively safe method, they do not adequately discuss its side effects. Now, what this does is, on one level, it creates fear among women when they face menstrual irregularity or amenorrhea, and on the other hand, they feel discouraged to visit the facility for complication management because it has been either posed as a minor issue or refuted altogether. So what happens when side effects occur is that ill-prepared women are often pushed towards method switching or discontinuation. Speaking about some of the motivations, many Ashas felt motivated by the fact that initiating conversation on family planning has become much easier now. Earlier, when they faced challenges in even entering the household, they are now able to broach the conversation on family planning with not just daughters-in-law, but also family members. There is an increased recognition of the role that key gatekeepers, such as the mother-in-law or the husband, play in facilitating not just access to the woman, but also their role in the adoption and continuation of contraceptives. The data shows that about 92% of Ashas reported including the mother-in-law during their counseling. At the same time, while there is an increased recognition of their role, a major challenge still remains the difficulty and hesitance in counseling husbands or convincing them to use FP. Despite several programmatic efforts on ground, this is still a challenge also because this still remains a challenge because the hesitation is still there, and programmatic efforts are also need to be sustained and long term to actually bring about gender norm change and social behavior change. Also, the hesitation is linked to the fact that Ashas come from the same community that they serve. They sometimes feel vulnerable when discussing family planning. For example, when side effects such as menstrual bleeding, menstrual irregularity occur, it causes weakness and illness in the woman's body, which affects her ability to perform day-to-day household chores, which also leads to resistance from the women as well as the family towards antra use. So the fear of backlash and repercussions is always present and acts as a barrier towards effective service delivery. Going forward, we feel that there is a strong need to provide Ashas with comprehensive information on injectables, particularly and most importantly on side effects and their management, so that fears and concerns that women and their families have around these areas can be reduced. Ashas must be encouraged to promote the full basket of choice so that informed decision-making can be facilitated and not fall prey to individual perceptions around method appropriateness. Thirdly, we saw that Ashas often do not approach women before first birth due to prevailing social and cultural norms. And we feel that this practice can change if Asha's own gender norms are transformed. Lastly, strengthening Asha's counseling skills and providing them with appropriate job aids can help them overcome personal and social barriers that they face during service delivery. Thank you. That was a short presentation.
Thank you so much, Falak. You presented before the time. That's good. So in this series, the next presentation is by Soumitra Ghosh, and he is working with ABT Associate International based in Afghanistan. So may I request Soumitra to please continue presentation.
Okay, so good morning, those who are here physically, and also I don't know how many, but there must be some online. So good afternoon, good evening, good night, whatever. My name is Soumitra Ghosh, and I'm Chief of Party for Afghanistan on behalf of ABT Associates. And I and my co-author, Ram Ganesan, who's also from ABT Associates, we welcome all of you for this presentation on this initiative where the private providers' knowledge and counseling skills were addressed and improved so as to address the myths and misconceptions that prevail among the women in Afghanistan. So this is this effort was part of a global project called Sustaining Health Outcomes Through Private Sector, in short, SHOPS Plus. Good to see one of our partners sitting there, SHOPS Plus, MSI, Mary Stopes. SHOPS Plus was USAID's flagship global initiative in private sector health, essentially working to harness the private sector, potential of the private sector, and also catalyze the public-private partnership. Led by the APT associates, the project worked in about 30 countries over the last 7 years, and it covered multiple health areas, including family planning, and family planning budget was one of the highest in the entire basket. So globally, among many other health outcomes, SHOPS Plus delivered 3 million couple years of protection, and almost 50% of that was contributed by Afghanistan. And my presentation would be focusing on Afghanistan today. So SHOPS Plus started in Afghanistan in October 2016, and it ended in September 22. APT continues to operate and provide family planning services and other priority health areas with the support of USAID funding. And we have been working with a leading social marketing organization in Afghanistan called Afghan Social Marketing Organization. Essentially being a social marketing organization, as you would know, like, you know, they promote and sell affordable modern contraceptive methods. And they use a nationwide network of about a little more than 2,500 pharmacies in the market. And they also generate demand through a variety of social behavior change initiatives, which is multimedia in nature. ASMO has a significant contribution in Afghanistan's modern CPR. According to the Afghan Demographic Health Survey 2015, which is the latest data which is available, it contributed over 22% of national MCPR, just one organization, so you can imagine. Talking about Afghanistan, many of you would know, like, it's one of the countries which has some of the worst health indicators in the world, and regionally speaking, it has one of the lowest MMR, one of the lowest MCPR. You name indicators, and like, you know, you will find Afghanistan ending with an A, like, you know, all the indicators. So there are many social, cultural factors that have been, you know, sort of contributing to these performances. There is no doubt that there has been a tremendous improvement over a period of time, but these cultural factors are key barriers or pose key barriers to access or use of various methods. First of all, in Afghanistan, if you talk about family planning, it is associated with, in a typical urban community, it will be more of OBGYs, the gynecologists, okay? But if you go to the rural or slightly lower income groups, you will find that, you know, they are associating with the midwives. Afghan women, by the social-cultural norms and also their own belief, they only prefer to go to the women doctor, okay? And unfortunately, you know, whether it is the gynecologists, okay, or you're talking with the female doctors, they're very few in numbers. And so therefore, their access is naturally very restricted. Family planning is a taboo subject in many countries, but in Afghanistan, it is slightly on the higher side, and it is as much a taboo among the beneficiaries as the providers. So providers also find it extremely difficult to initiate any kind of counseling, any kind of topics on family planning. They can talk about water, they can talk about anything else, but not family planning. Socio-cultural factors, if you see, like, you know, women, they are sort of restricted by the, you know, in terms of their autonomy, in terms of their decision-making authority, even mobility. I mean, for example, if you see the DHS, you will find that a woman to go to a doctor or a health center has to be accompanied by either a husband or a brother or a family member. And so therefore, accessing the health services become that much more difficult for them. And lastly, the very lack of opportunity to speak about you know, what they know, what they hear, okay, with either the provider or with the family members or the peer and friends, what happens is that it leads to insufficient knowledge, inaccurate knowledge, and including a number of myths and misperceptions that exist in their mind. And people say that, out there, there's general belief that the Islam doesn't allow family planning. But if you talk to the imams, if you talk to the scholars there, religious scholars, they don't agree. They said, no, that's not true. So, but the population, because of lack of discussion, lack of engagement on these kind of issues, they are forced to believe in those kind of things. So one other important thing to note is that Afghanistan's private health sector is a very important source of care, especially when you're looking at the 5 large urban provinces, which account for little over 55% of the unmet need in family planning. So just 5, if you concentrate, you can make a huge difference in Afghanistan. I mean, of course, that large urban provinces contribute to a large population as well. With shortage of specialists and women doctors, as I was saying, so the general physicians and the midwives in 2 different sort of segments of the population become the major source, and they're very large in number. For example, midwives, there are over 30,000 midwives available who are private midwives, okay? And similarly, the general physicians, they're a big number. But unfortunately, the GPs, as you know, they are not really trained on family planning during their medical education, nor, I mean, we have seen some of the government training programs and some of the development sector training programs, they don't really include the general physicians there. It is more the focus on OBGYs and the midwives. So given that, we felt that, if really we have to sort of initiate this whole counseling, we need to sort of engage the private sector providers, both the GPs as well as the midwives. Now, given the focus of social marketing, which is more of the low, middle or middle income group, we found that the general physicians are a better sort of the provider rather than the midwife, because the midwife is really into the urban slums you're talking about or in the extension areas of these urban areas. So therefore, we supported ASMO essentially to train and detail OBGYs and the general physicians. Now, for those who are not very familiar with the term detailing, training, all of you know, detailing is essentially a one-on-one marketing technique used by the commercial pharmaceutical companies. The focus is like they sort of train the doctors or orient the doctors on their products, expecting them to sort of prescribe that product so that sales go up. So we borrowed that technique and we basically used it to train the doctors and reinforce the messages on family planning and the methods and the products along with its side effects, okay, and how to manage so that they become more knowledgeable. And they actually, I mean, we also focus on the soft skills so that they start discussing those with their clients. Simultaneously, the clients who are waiting in the clinic, at the waiting room, they were also being sort of sensitized by the midwives who were sort of doing the detailing, so that these women, they can actually get to know, and they were being encouraged to go and ask more questions to the trained providers so that they get more accurate information from these providers. So as I said that ASMO generally focused on the OBGYs and the GPs. And so to start with, we did a baseline survey. And very interestingly, what we found that, the baseline showed that the providers do not routinely lead quality family planning counseling. And that's very important because they're not initiating the discussion. So it is usually started when a client asks a question about a method or some problem that she is facing, then only the discussion starts. So this study, which was done in September 2019, we focused on 1,000 case observations, which is family planning related cases, okay? And what it showed, I'm sorry. Okay. What it showed is that slightly more than half of the patients or consultations, they received guidance on family planning in general terms, benefits, the side effects, and how to use these methods and how to sort of manage these side effects. If at all the counseling took place, the provider recommended a method, okay? And interestingly, 25% of the pregnant clients experienced an unplanned pregnancy. But if you see the less than 4% in cases where the doctor actually asked them about their family planning history, what method they used, or any counseling took place. And so it's a clear case of a loss of an opportunity, even if you look at it from the PPFP point of view. Lastly, they really had, because our partner was ASMO, so we were focusing more on ASMO. Of course, the MSI brands are also popular there, so we covered MSI brands. So ASMO enjoyed a good quality, reliable sort of reputation among these providers that we covered. So the theory of change that sort of helped us to design the initiative. So the focus was on improving the knowledge and attitudes of both the providers and their patients, okay? So what we did, we used the master trainers of Ministry of Public Health, who are certified by the Ministry of Public Health, to train the providers and the detailers, which are the midwife interns that we recruited. And these trained detailers actually conducted detailing after the training. So they go on a frequency and meet the doctors, and they sort of reinforce the key messages of the product benefits and so on and so forth, okay? And simultaneously, they're there at the clinic. Those patients who are waiting at the clinic, they do sensitization of that. So the idea is that if the knowledge increases, attitudes improve, that will lead to more confidence. So therefore, there would be more of counseling by the provider and inform accurately about the family planning. And patients also gain more confidence to discuss with their husbands, family, peers, so that social support increases. And armed with this information and confidence, they then sort of go to the pharmacies where ASMO is talking, and they start buying the family planning. So that is theory of change. So what did we do? As a preparatory, as I said, we selected 1,000 private physicians and 20 midwives nationally, essentially to conduct the detailing exercise. And this 1,000 private physicians, it included basically OBGYs and general physicians. We developed training and communication materials in partnership with the Ministry of Public Health, essentially to also use the clinic as a medium for communication. In terms of execution, we could train 577 providers. We failed to train 423 because by then the COVID had struck and everything had to stop. We conducted detailing and sensitization and replenished stocks, so those clinics also sort of stocked the family planning so that they can sort of be given to those or sold to those clients. In all, from start to the stop, which is around the COVID time, it conducted about 2,000 detailing visits, and it covered over 100,000 sort of patient sensitization. We realized that, it is important to sort of monitor this and understand whether it is making any difference or not. So we actually plan to go for that observation study of the consultations that are happening. And so, as I said, we trained these midwives on observation, recording, and confidential reporting, because if the doctor gets to know that he or she is being sort of, monitored, or so there might be a bias in their behavior. So these observed and recorded the family planning. Wherever a consultation was family planning, they recorded the conversation, and they saw that what was the protocol followed, and also the doctor recommendations were noted down. So as I said, the baseline was in September. We've planned the follow-up assessment in June, August 2020, but it got canceled due to COVID-19. And then when we wanted to start, came the August 15th, 2021, the Taliban takeover, and so obviously we couldn't do any kind of follow-up. So today, what we are constrained with is that we can talk about how a doctor prescription or a doctor recommendation play an important role in ASMO's brand sales, but we are still not in a position to comment whether the patient counseling quality has improved dramatically or not. So what we did was we used other surveys, like ASMO does brand audit survey among the pharmacies that they stock, okay? So we checked, what is the perception of the pharmacists on various brands that are available in the market, sales, and what actually contributes to sales or acceptance of a brand. So we used that data. And what we found was, if you compare Asmo brand, say on the left, what you see is the OC brands, and on the other side, you see the injectables. So for OC, Koshi which is the Asmo brand, was associated 75% as the main reason for sales being doctor recommendation. And the closest second brand was 7% for OC. It's very similar picture for IC as well. It's a 72 versus 11. And when we ran the correlation, we found that, the doctor recommendation play a very critical role for Asmo being asked for by the buyers. And also when the pharmacist is recommending, okay, take this to a generic buyer, let's say, give me an OC kind of a customer. So they are saying that this is usually recommended by the doctors. So this is, again, it's a surrogate measure. It doesn't really necessarily tell you, like, what is the impact of the initiative. So what we have done, we have now adopted, given the change scenario in Afghanistan, that how to make this initiative sustainable. So first of all, there were a number of challenges following the Taliban takeover. It really threatened sustainability because there were massive exodus of trained providers. I mean, the ones we trained, they left the country. I mean, whether it's midwife or a OBGY or a general physician. And there was this uncertainty, it's still valid, uncertainty around family planning and safety of women providers, So therefore, it took a little time. But USAID continues to support us, with their funding, essentially to, for the well-being of Afghan people, especially the women and the lower income. So with that, we realized that, instead of focusing on the GPs and the OBGYs, it's better to focus on the midwives now, because that is where the real problem is. The economic situation demands that. And so therefore, Asmo now has recruited nearly 350 to start with midwives, and they're working with them. And we are now expanding that nationally across all 5 provinces. And so what we have done is, it is built on the previous experience, that what we learned from those observations. We also, they provide detailing and mobilization support to the midwives, clinics, and their patients. And the referrals, we have also built a referral system now with the nearby hospitals and the solo practitioners, OBGYs, so that, any kind of complication cases can be easily referred to these places. So as I said, like, this tracking and monitoring system is being implemented, and I hope by the next ICFP 20 whatever, okay, I'll be able to get back with some results. Thank you very much, and I know we'll be always constrained by the time, so if you have any questions, this is my email. You can always sort of send me. And there are some very limited number of leaflets available, so you can just pick it up. I'm keeping it here so that it helps you to know more about APT and Shops Plus. Thank you very much.
Thank you so much, Samitro, for your presentation. So in this series, the last but not the least, we have Mathia. So she is working with Marriott Stop International, and her work focuses on Sahel region. So Mathia, please come and present your presentation.
Thank you, and good morning, and good afternoon, evening to those online. As mentioned, my name is Matea Romer, and I work with MSI Reproductive Choices in the Global Office as an Evidence Innovation and Research Manager. And I'm really pleased to share with you today results from a pilot evaluation that explored the impact of an innovative digital solution called Community Connect on increased access to sexual and reproductive health information and services in the Sahel. And I'd like to acknowledge the long list of co-authors who made this possible. So why did we decide to invest on enhancing our support for community-based mobilizers, or CBMs? Well, we had learned from our previous work with CBMs that they were vital in driving awareness and improving access to SRH services in the communities where MSI operates. Our client exit interviews indicate that about 1 out of 3 clients are referred by a CBM. And importantly, we know that they reach segments of the population that other sources of marketing do not, such as adolescents and those living in very rural areas. We also knew, this is very sensitive. We also knew that sites that are mobilized by these community-based mobilizers reach about 56% more clients than those that are not. And due to the growing smartphone saturation and improved network coverage in sub-Saharan Africa, including the Sahel, we saw an opportunity for innovating in the digital space to support these CBM's work. However, what we didn't know was what the overall reach and effectiveness of our CBM networks were, or which activities are best at reaching different segments and converting them into clients. And we also didn't know if we could improve job satisfaction and overall CBM network performance by digitizing some CBM work processes. So we sought to fill this gap by supporting CBM's day-to-day with a digital solution. And this was supported by the Bill and Melinda Gates Foundation. It was a 5-year project implemented in the Sahel, in Burkina Faso, Mali, Niger, and Senegal. And we began this project with a design phase to understand what the users, our CBMs, needed and would be able to integrate easily into their day-to-day work. The design phase was followed with a pilot in the 4 Sahel countries, during which we built the app, tailored it to the CBM's and country programs' needs, and implemented a staggered rollout beginning in Senegal and ending in Niger. And we completed this pilot phase, the initial pilot phase, with an evaluation, and then used the findings from this to inform a scale-up in the 4 countries. And we completed this pilot scale-up phase with a final evaluation, which has started earlier this year and wrapped up in June. And so what was this digital solution? We've called it Community Connect, or COCO, and it includes a diverse set of digital functions. There's an activity tracking app, which allows the CBMs to track their demand generation activities and produces data that allows them and their supervisors, and also those in the support office, to better understand the effectiveness of their activities and provide supervision. There's a behavior change communication app, which allows them to access a digital library of communication resources, including videos on various FP, family planning methods, pregnancy, menstruation, and more. There's also a referral tracking app, which allows them to make referrals, which are then sent to providers that they support. And within the app, they can follow up or track and follow up on these referrals, and then they also see when the provider confirms that referral at the time that the client shows up for a visit. And additionally, there's an app that allows community-based mobilizers who directly distribute short-term methods in the community to track this distribution. And lastly, there's an application that supports with tracking supervision visits and monitoring our CBM performance. And as I mentioned earlier, during the pilot phase, we developed various iterations of the application to ensure it was adapted for every context. So this included developing both global features that were rolled out across all countries, as you can see here, and then some program-specific adaptations, such as locally translated videos. And then we also learned during the pilot phase and design phase that not all CBMs were comfortable using the smartphone version of the application, so we also developed an SMS version of the application to specifically support users in Niger and Burkina Faso. And a really big priority during this pilot project was integrating evidence and learning into both the design and implementation of Community Connect. And so today I will be presenting on the results of the final evaluation, but as I mentioned earlier, there's also lots of learning integrated into the formative design phase and then following the initial pilot. And the aim of the final evaluation was to understand the feasibility and acceptability of deploying and scaling up the use of Community Connect and the short and longer term benefits of CBMs using Community Connect. And specific evaluation questions were focused on the effects of Community Connect in terms of expanding access to FP services, client experience, driving social norms and behavior change, and both operational and strategic benefits. And to respond to these various questions, we used a mixed methods approach. And for the qualitative component, we used both in-person restricted focus group discussions, or triads, and structured in-depth interviews with a range of key stakeholders, as you can see here on the slide. And for the community-based mobilizers, we purposefully sampled both those using the Android version and the SMS version to have a diverse representation of experiences. And for the quantitative component, we conducted structured interviews with the community-based mobilizers and their supervisors, as well as analyzed routine client visits data collected during the initial pilot and the scale-up phase of the project. In our analysis of the client visits data, we used a quasi-intent to treat pre-post difference of difference analytical approach, which is a mouthful, to understand if there was an effect of Community Connect, if any, on a range of quantitative outcomes in the project sites relative to non-project sites. So those sites where there's still community-based mobilizers supporting our providers, but they're not using Community Connect. So what did we find? The results demonstrated that Community Connect is feasible to roll out in these contexts and is highly acceptable by the community-based mobilizers and the clients. The CBMs using the application have provided SRH pre-service information to over 688,000 people. And as one can see in the chart down at the bottom, the majority of the people being reached in the blue are women, but we are still reaching men. In fact, almost 1 out of 5 people being reached by these community-based mobilizers are men, and about 1 in 4 are adolescents. We also found that Community Connect is really supporting SRH service referrals, and the client follow-up is easier and more effective with the application. And the potential clients are really satisfied with their experience of interacting with the CBMs using Community Connect, and they value the increased security that the application offers for that referral process. And they also found the videos to be very engaging and to help them understand the various FP methods available to them. We did note some higher satisfaction reported among the Android app users compared to the SMS version. For the analysis of the routine client visits data, we saw varied results across country and channel. And we saw the greatest effect in Senegal among our Mary Stopes ladies. These are single provider who are trained typically as midwives who offer services both in static facilities and in an outreach model. And what we found there, that for these Mary Stopes ladies supported by community-based mobilizers, we saw a 1.5% increase in client visits, in adolescent client visits to these providers compared to those that were not supported by the application. And you can see here in this graph, the blue bars are average adolescent client visits per Mary Stopes lady supported by Community Connect, and the pink bars are visits to the other Mary Stopes ladies. And in the yellow here, you see that the application was launched in February, and this is confirmed adolescent referrals to these Mary Stopes ladies. And you can see, following the launch, impressive increase in the blue bars, which again represents those adolescent visits to the Mary Stopes ladies, and you do not see the same increase in the pink bars. So this shows potential impact of this application in the specific context, but we did not find this across the board. And what might explain this is represented here in the chart on the left. As you can see, the MS ladies, or MSL in Senegal, are reaching a higher proportion, or the community-based mobilizers supporting those are reaching a higher number of adolescents, which is the bright blue, than the other channels. And this is because they are supporting Mary Stopes ladies who have a specific training and approach designed to reaching a higher number of adolescents. And we've also trained these community-based mobilizers to understand specific approaches that can reach this key population segment. So I think this indicates that the application is really an aid that can enhance work that mobilizers are already doing. And if they're well positioned to reach this client population, the app might make their effectiveness even greater. And as hinted in the previous slide, we found that this application is improving the CBM's pre-service counseling, and specifically through the use of the videos that were included in the behavior change communication application within Community Connect. Both the clients and the CBMs reported that these videos are really helping in shifting acceptance of FP methods and potentially shifting overall social norms and behaviors within these communities. The videos were highlighted in the qualitative interviews as a really effective way to combat rumors and stereotypes about family planning methods, and the CBMs reported a change in acceptance of FP use in their communities, as I mentioned. This was not something that we could evaluate in the quantitative component, but really came out strongly in the qualitative interviews. And the last key result that I would like to highlight is how Community Connect has supported the adoption of a data-driven decision-making culture, and through this reinforce the quality of community-based mobilizer-led pre-service counseling and overall performance. As part of this project, we work to ensure that data is readily available and visible to stakeholders by developing reports in ComCare, which is what this application was based on, as well as a dashboard in Power BI that was updated in real time. This helped to establish a continuous thread of data visibility between the community-based mobilizers and their supervisors, as well as those in head office, to improve CBM performance management via better detection and quicker detection of support needs and more targeted incentive schemes. And in the qualitative interviews, the CBMs reported how Community Connect has not only decreased their data reporting burden compared to when they had to report data back to us on paper forms, but the visibility of the data through the reports that they can see in their own version of Community Connect has also supported them in tracking their own achievement of targets so that they can achieve those incentive schemes and overall just improve their overall satisfaction in their day-to-day work. So I know this has been a lot of information, so I'll quickly summarize the key takeaways and key lessons learned. So the results demonstrated that digital solutions for community-based support tools are feasible in the context of these 4 Sahelian countries and can lead to improved CBM-led pre-service counseling, increased referrals for SRH services, as well as increased referral confirmation rates and improved job satisfaction for community-based mobilizers. Specifically, Community Connect is supporting CBM's day-to-day activities thanks to the videos that have enhanced the CBM-led pre-service counseling and the digitized referral system. When we compared across SMS and Android app users, these perceived benefits were greater for the Android users. It is facilitating the tracking and follow-up of referred clients with higher referral confirmation rates observed in static versus mobile service delivery sites overall. We have also seen that with an established supportive system for adolescent-friendly service delivery, Community Connect may support increased access for adolescent FP clients specifically. And thanks to the increased data visibility in Community Connect, it's supporting incentive-based remuneration schemes and overall CBM job satisfaction, and the improved visibility of CBM performance has also facilitated more rapid detection of support needs and led to more targeted and enhanced support and supervision to these CPMs. So what does this all mean for our sector? Well, developing a digital support tool, or really any support tool, it's key to have user involvement across design, training, and deployment. Supportive infrastructure should be a minimum requirement, and CBM selection can make or break the success of implementation. Motivation really matters, and representative incentive schemes of CBM's work, and these must be also delivered on time to really ensure that overall increased motivation. And the centralized and accessible data, as was made possible with Community Connect, facilitates performance management and decision making. And you can see most of these key takeaways are really systems focused and not specific to Community Connect necessarily. And that's because any digital support tool, I think, is really just an aid that can enhance the work that's already being done. But it's really essential that we have the right CBM selection, training, deployment, and that we use the data available to improve the overall performance and ultimately increase access to SRH services. Thank you very much.
Okay, so because the audiences were not on the time, so we started late. And as we started late, we are left only 5 minutes for the quick round of question and answer. So the floor is open for you people. So may I request you to please quickly ask your question. We will take 2 to 3 questions all together. Then we will request our presenters to answer those questions. They will on the mic. So, okay. Okay.
Yeah, thank you very much for all the presentations. My name is Nondo. I'm from Tanzania. My question is to the first presenter.
First.
She talked about the social analysis approach, the social analysis and action approach, and she also talked that they have developed a toolkit. Sorry, they have developed a toolkit based on that approach. I was wondering if there is a way or there is a link you can share with us so that we can look at it and see if it can be adapted to other contexts, and if we can have that permission to adapt it. Thank you.
Okay, we can take one to two more questions, then we can ask the presenter. So any questions from the audience? Yeah.
My question is to the presentation from Afghanistan. I saw there was a mention of 44% of pregnant women having anemia. This is worrying. Is there any active intervention around that? 44% of women, I don't know, you mentioned something like that. Then my second question to the presentation from MSI is what is the mobile coverage? I don't know in the countries where they're working, and is that a challenge? Something like that.
Thank you so much. One more person can add? Yeah. So first
Thank you so much. My name is Victor from Malawi, and I have a question for Coco. I saw from your statistics that females access the app more than males. I wanted to know the reasons why and what are the solutions that you have for that. Thank you.
Thank you so much for the wonderful presentations. My name is Dopsadi from Chad, from Sahel. My question is who she presented the final one. In Sahel, we are facing about the problem of connection and talking about a digital support tool that you implemented in Senegal and Niger. My question is, what were some challenges that you faced before implementing this project? And I invite you, maybe one day you will be in Chad in my country too. What are some challenges with connection, with light you're facing before implementing this project? Thank you so much.
Okay, thank you so much. So we have question for Padma and Komal, Somitro, and then Mathiya. So Padma first.
Yeah. Thank you so much for your interest in knowing details of SAA. This is a model developed by CARE USA, and you can get the details in the resource section of CARE USA's website. We actually adopted those tools and modified them to suit to the Bihar's context. So the base tools would remain the same, but we have to tweak them to suit to the context, and it's available in CARE USA and at the CARE International website as well. Thank you.
Thank you for the question. This particular initiative which I presented focused more on family planning and a little bit of maternal and child health, but main focus was family planning. Nutrition, malnutrition and anemia is one big area, and our current initiative with the midwives and other providers, it covers nutrition in a big way. And we are working with various other partner organizations. There is Save the Children, there is various other organizations who are also working. So this is, in Afghanistan, one of the major causes of MMR. So there's a number of interventions there. And we can have a separate discussion on that. Yeah, thank you.
Thank you so much. Mathiya?
Yes, thank you for that question. In terms of network coverage, that varies across the 4 Sahel countries that were selected for this pilot, and also within regions of the project. So we did intentionally select CVMs that were working in areas with higher network coverage, but we still found, because we wanted to have a subset of those supporting our last mile service delivery through our mobile outreach approach in more rural areas. And we did run into challenges there with network coverage. And then this also links to your question, the colleague from Chad, that we did run into a lot of challenges around just systems level issues around connectivity, digital literacy. So that's why we developed the SMS version of the application, because we found a lot of these community-based mobilizers are retired midwives in their 70s who've never used a smartphone before, and are even challenged to navigate through all the functionalities of an SMS simple like Nokia phone. So that came out of that formative research, but we had already signed up for this project. So we moved forward with it. But our key lesson learned from this is that we're going to try to scale in countries that are more established in terms of digital coverage, and where also the clients are more used to interacting with an application. So we're moving this forward to Kenya, where mobile money has exploded. So everyone knows how you send a transaction through a phone. So sending a referral across phones isn't a surprise, doesn't need a lot of time to explain. So I think we'll probably hold off from scaling further within the Sahel region, maybe just wait a few more years for coverage to catch up there and for the population to be more familiar with digital tools. And in terms of the question around reaching more men, our community-based mobilizers do specifically target women because those are who they want to refer for services. But we did find that with the application, more men were being engaged. We heard in some qualitative interviews that women would bring their partners back to the CVM to ask the CVM to replay the video so that their partner could also watch the video on an IUD and implant and understand it better. So through the qualitative evidence, we think that the applications can support male engagement as well.
Okay, thank you so much. I'm sure there might be more questions, but because of shortage of time, I'm stopping the question session now. We can connect with the presenters outside this room. And I thank you all the presenters once again, as well as the audience. And now we are announcing that officially this session is closed. Thank you so much, everyone.
Thank you.